No one else in the waiting room, so I think we'll kick off. Welcome, everybody. For those of you who don't know me, my name is Mervyn. I work for the ITP Support Association. Tonight's meeting, as they always are, is actually being recorded, so people who can't attend can actually have a chance to actually look back on them. And they are becoming very popular on our YouTube channel as well, where people use them to actually look up things and all that and see what questions are being asked. As always, please try and keep muted unless you're actually asking a question, because background noise can be a bit sort of disconcerting. I'd like to introduce, before we start, a few people who will be on the call. Firstly, Professor Adrian Newland. Professor Newland is the Chair of Trustees of the Association, and he will be here on hand to answer any of the real sort of medical questions. We've also got with us Mrs. Rhonda Anderson. Rhonda is the Senior Patient Mentor for the Association, along with another patient mentor I see there, Karen. Welcome, Karen. We've also got a couple of board members, Mr. Derek Elston, the trustee of the association, and the patient observer for the board, Mr. Anthony Hurd. Welcome both. Right, so is Sue Wheeler here at the moment? No? Sue, do you want me to ask your question, or would you like to do it yourself? You're on mute, my love.
Right. The question I sent to, hi everyone. I've joined a couple of these meetings. I was diagnosed with ITP following the AstraZeneca vaccine in February, and my platelets have gone up and down with varying treatments. And at the moment, my haematologist was seeking advice, a second opinion. And I just wondered if other people had started ITP in this way from COVID, from vaccines.
Yes, thank you. That's an interesting question. Certainly, a low platelet count has been picked up in most vaccines. Actually, we've known about it for many years from the normal childhood vaccines, where it happens in about 10 per million. In the two vaccines that are used in the UK, this is in people who are otherwise normal, or we think normal. There are very few people who are normal, have a platelet count beforehand. With the AstraZeneca, it occurs in around 17 per million, and with the Pfizer vaccine, it occurs in about 7 per million. Now, normally, when it occurs post-vaccine, it occurs about 2 to 3 weeks post the vaccine.
That's true.
And in those, it's probably directly related to the vaccine. In the normal population, the incidence of ITP is about 6 per 100,000. So that's about 60 per million. So that's actually quite a lot more than we see as a reaction to the vaccines. And what we think is that for those people who develop a low platelet count within 2 or 3 days of the vaccine, which is really too quick to be the sort of reaction to the vaccine itself, we think they've probably had an underlying ITP that's been highlighted by the vaccine. Now, what I would say is the vast majority of people who develop this sort of new ITP post a vaccine, the vast majority completely recover, and the vast majority never need treatment. A small amount have needed treatment, and the counts bounce up very quickly. So if you've had a count you've required several treatments for it, it's not been stable, that is unusual and suggests that you have true ITP. So
right. Without obviously the other people don't know all the detail, but it started 10, 12 days after vaccination. Yeah. And I've had romiplastin now for 32 weeks, having gone through the standard steroid stuff first. And I'm going to see what the COVID booster does to me tomorrow.
So have you responded to the riflastine?
I can probably keep the count now over 60.
Yes.
But occasionally it'll go 190 and then drop again.
Yes. Well, I mean, that certainly suggests that you do have a true ITP. And what we normally do with the riflastine is if it's bouncing, if it's remaining above 50, we treat for at least 9 months to 12 months and then try and tail the drug off. And in about a third of patients, the count will remain up off all treatment.
And
so
I've been quite intolerant to the drug, so they've just got me to tolerate 150 ml. I'm still struggling with it.
Okay.
But yeah, but thank you for the.
What I would say is that the reaction, as far as the data we've got, the reaction to the booster count is much less than a response to the first injections, vaccinations. So the fact that you've had it once doesn't necessarily mean that you will react in the same way again. So
I reacted after the Pfizer for the second one.
Did you?
I'll have more data next week then.
Okay, best of luck.
Okay, thanks very much, Sue. Any other questions before I have got another one, but any other questions?
Excuse me, can I say something?
Alison and then Jeff. Alison, go on.
Hi, I developed ITP after the AstraZeneca and had and have been stable at about a level of 60. I've had 2 hospitalizations, was stable at 60, and last week had my AstraZeneca, I had the
booster.
I had the booster last week. Sorry, my brain.
Which would have been Pfizer. Which would have been Pfizer.
No, I didn't have the Pfizer. I had the one beginning with M.
Moderna.
Moderna. I went to my levels were 175 last week at the haematologists, and this week went in on Monday, and my levels were back to 16.
Okay. It's interesting. We don't have much data on the Moderna vaccine. It's just not been given to enough people yet and collected by the MHRA for us to actually have any good data on that. So that's interesting. As I'm sure most of you know, they aren't using the AstraZeneca vaccine for the booster dose. It's all either the Pfizer or the Moderna, depending on what you had first time round.
Yeah, in a patient COVID survey, I think we've only had a handful of Moderna patients.
Yes.
At all. So, okay. Thank you very much, Alison.
Looking at the MHRA website, where you can get all this data from, the vast majority, the most vaccines have been AstraZeneca. The next are Pfizer, and they make up the vast bulk, and about, I think it's less than 10%, and less than 5% were the Moderna vaccine, and that's related to availability and the fact it came in later than the other 2.
Thanks very much, Adrian. Thank you. Jeff, you had a question.
Yeah, thanks very much. I'd just like to get a clear idea what stable is, because I like Sue, I got the job in February, AZ, ended up in hospital in March. Because it dropped down to, well, it crashed. Platelets had crashed completely. I'm now around 59. I've been on Revalade for since mid-August, but it sort of bounced up a bit. The highest I've been is 79, or sorry, 72, but always keep dropping back down and down towards 50 or below 50. So is Revalade working, or what should I be looking for as being stable? And currently I'm being advised I might be able to get my next job. I haven't had a second job, as I say. I'm being advised just to hold off, but I'm not really sure. Yeah. The way things are going at the minute, should I hold off or not?
Did you have ITP beforehand, or were you, as far as you're aware, normal beforehand?
Oh, it's not. Okay, the only condition I've had beforehand was diabetes, so I have had for regular blood tests. So my blood tests have always been normal. Okay. I've never had any issues at all.
Yes. Normally with the Revalade that you're taking, which is the Thrombocytopenia, We look, and with the romiflostin or the end plate, we aim to adjust the dose to maintain a platelet count above 50. If it goes higher than that, that's fine, as long as it doesn't go over 150, 200, that sort of level. We aim to try and keep the count between about 50 and 150. Because it can sometimes bounce very high, and there's a risk of clotting if it goes too high. I think while your count is bouncing around like that, it's quite reasonable to delay the second dose to see if you can actually reach a stable position. And as Alison said earlier, that you can see the count crashing, although we've seen it both ways. One of our advisors, one of the ITP community from the Southwest, her count crashed with the first dose. She had the second dose and it actually then bounced right up. So it can go either way, and we see quite a number of the counts actually increasing post-vaccine. It's unpredictable. Obviously, it's less of a risk if it goes up, although there is a clotting risk if it's too high. But obviously, we see it both ways. Just as one of the reasons I asked about whether you had pre-existing ITP is that the risks of the count falling if you've got ITP and have the vaccine, we see the count falling between about 10 and 20%, and in the majority of those, it's transient and very rarely drops to very low levels. And again, it's much more common with the first dose than with the second dose. It's about the risks are about half that with the second dose.
Okay, was that okay, Jeff? Great stuff. Okay, Jane Bailey. Jane, I think we've probably answered this question, but do you just want to put your question about the vaccines and the mixing of doses?
I sent you an email. Hello, Mervyn. Yeah. Hello, everyone. But I don't actually have it in front of me. Do you have my question there? If you could read
I have.
Out,
yeah.
I think you've covered quite a bit of it. So
yeah. But I think it's been answered. But basically, Jane's email was, I had a letter from the haematology department inviting her for a booster dose of the vaccination. She said her first 2 doses were AstraZeneca. Is there any likely health impacts if they mix the dose and it's Pfizer? But as you've now also said, it can be Moderna as well. Yeah, I think the answer is no.
The vaccines are slightly different and act in different ways, and there's a general feeling that it actually boosts the immunity if you have different vaccines, because they're actually causing slightly different forms of immunity, and those 2 forms are additive and give you more protection than just one of the vaccines alone. So it's and the Moderna would be the same. So it's quite safe to mix them, and indeed there are potential advantages in terms of protection of having that mix.
Okay, does that answer the question, Jane?
Yeah, the letters I've had from the hospital refer to a 3rd dose. So I was just getting a bit confused. Is the 3rd dose the booster, or is it the booster? Is it one of the same?
It's one of the same. It's bizarre terminology that even I fail to understand. When they first started doing it, they called a booster. They're now calling it the 3rd dose, but it's actually the same as the booster. It's 6 months after your 2nd dose, and they're now saying, well, we'll give you another booster next year. So I think we're going to be having yearly COVID jabs along with our flu jabs forever.
I think Karen's got her hand up. Yeah.
I've got a comment. I've got 2 comments.
By the way, I had 2 AstraZeneca followed by Pfizer.
Yeah, so did I. That's the best thing.
Sorry, Karen, I was talking over you. Carry on.
That's okay. I've also got CML as well as ITP, and there's that's counted as being extremely clinically vulnerable, and we're all being made to have our booster stroke 3rd dose listed definitely as a 3rd dose, and then we have another booster in 6 months' time, and I think that might be applying to some other people in hospitals as well, depending on how their haematologists have categorised them. That's my understanding of it. Leukemia
yes,
care.
that's absolutely. That's absolutely right. Anyone with a hematological malignancy, the chronic leukemias as you've got, or multiple myeloma, which is another condition, more chronic condition, the response to the 2 jabs is probably less, probably around 40% efficiency. So they're trying to give the 3rd dose and then a booster, then plan for a booster in 6 months, which they aren't necessarily doing in the normal population. But I suspect that even the normal population, sometime by the middle of next year, if we're getting our boosters around now, will be invited to have another. But you're exactly right. That's what they're planning to do for someone like yourself, whose response would be less good to the initial 2. So they'd want to stimulate you and then do it again.
I gather there's been quite a lot of confusion, though, with GPs and other health services and providers as to how they're actually designating when they send out the call-ups to go in for the booster. Some people are being called for a booster, and some people are being called for a 3rd dose. And
Yes.
there is some confusion.
There is. It's a bit cockeyed, I have to say, but it's a 3rd jab, whatever you want to call it, and it's a good thing to do.
Yeah, absolutely. And can I make a comment for Jeff, I think, who had the comment that he'd had his first vaccine and then crashed and been hospitalised. I was only in for a day, but I ended up very unwell with a platelet count of 1 after my first jab, and I'm a lady who subsequently on the 2nd jab had quite a nice rise in their platelet count. But I did say to him, well, we did discuss it with the consultant hematologist before I had the 2nd jab, and he thought that overall I was more at risk of COVID than of getting a COVID infection than I would be of having another platelet crash, why they kept an eye on me.
Yes.
And so overall, I took the decision with my hematologist that I would have the 2nd jab at the due date and risk another platelet crash, which I didn't have. But I felt better. It was better to be protected against COVID.
Yes, I remember you now, Karen. It was you who told me about. I just described your story earlier, didn't I?
You did. That's right.
It's a very interesting point that you make, because certainly within my own hospital, and I know, having spoken to other people elsewhere, all the patients on the intensive care units requiring ventilation with COVID are unvaccinated. All the severe cases in hospitals now are unvaccinated. The only patients who have severe problems with COVID who've been vaccinated are those with other severe health risks that makes them very vulnerable. And that's, of course, one of the reasons for wanting to give someone with your underlying blood condition, because the treatment that you're receiving stops you reacting to the vaccine quite so well, while they want to give the 3rd dose and then a booster probably sometime next year, because that enhances your immunity. But your hematologist is entirely right. The risks of infection, I mean, the risks of thrombocytopenia are 30 to 40% with a severe COVID infection. And if you have a low platelet count and the infection, because the count falls because of the infection, your outlook is much, much worse. So, and indeed the risks of thrombosis, of clotting that have been highlighted with some of the jabs are again much, much worse with the infection itself. And I have to say, when I get confronted with anti-vaxxers who say COVID is a hoax, I say you need to come and talk to the relatives of 1,000 people who died in Barton, London during the COVID epidemic. I mean, we've been very, very busy because we're such a big hospital with our surrounding area. I just can't understand how people can look at that data and deny that COVID is an issue. And the way to prevent that is, or to minimize the risks from it, is a proper course of vaccines. Sorry, that's my rant over. It's my hobby horse, that one.
Thanks so much.
I also get mask rage on the tube, but my wife tells me to shut up and read the paper. So I'm not allowed to say anything. Sorry. Carry on.
Rhonda, you got your hand up.
Actually, Rhonda's got a hand up.
Yes, I just wanted to, this has probably been already been said, but just to be clear, although they're calling it the booster, and you might think that it's different from what you've already had, it's exactly the same vaccine as you've already had. They're calling it the booster because you've had 2 already and now you're having another one. So it is actually exactly the same. It's not a different kind of injection or different kind of content. It's the same strength as the first 2 that you had. So that everyone you're having is exactly the same as the original ones that you had in strength. And so that is something I think people aren't aware of. They seem to think the 3rd one is somehow different. Well, it might be a different actual vaccine. I mean, I had AstraZeneca for the first 2 and then Pfizer for the 3rd one, but they're all, you know, the same thing, basically the same strength, the original strength. And I did have a bit of reaction to the Pfizer. My husband and I both had it on the same day in different places. And we did have a slight reaction, but I don't know anything about what happened to my platelets because I haven't been tested. But they're usually okay anyway. And I just want to say, you know, that it is really worrying for people who have peaks and troughs in their platelets, and especially if you've got the ITP as a result of having a vaccine. So it's really important to talk to your health professionals and get as much reassurance as you can. So ask them plenty of questions, make sure that you know what the situation is for you and what treatment you're being given and why. So we go back to the point that I often make. It's really important to have good communication with all of your clinicians so that you're totally aware, because that is one of the things I think that makes people anxious, is that they don't really know or feel that they understand or have been told or listened to about what is going on with what has happened to them and what the treatment is. So I would urge you to ask.
Thanks, Rhonda.
That seems to be the right time to publicize our little leaflet. Shared decision making.
I had mine ready as well.
Shared decision making. I hope most of the people on the call are aware of the document we put together, which is for patients to encourage them about shared decision making, to talk to their clinicians, their hematologists, about their treatments and what they're doing. It's something that the ITP Support Association initiated and developed and put together with representatives from the ITP Clinical Forum, which represents the main centres around the UK that treat ITP. And we had input from patients. Rhonda was part of the group. Anthony also looked at it. We had nurses on the group as well. And it explains the issues of ITP very simply, but it also explains the sort of questions you should be thinking about and asking your physician. We sent, I think Mervyn will know the right numbers, but we sent copies around to all the hospitals in the UK. We sent about 2,000 hard copies out. It's been downloaded now, I think 3,000 plus times.
Over 4,000 times now.
4,000, it's fantastic.
Yeah.
And we've been asked if it can be translated into various European languages as well. So we're currently looking at getting translated into Spanish and Italian and whatever.
Portuguese.
Bizarrely, the French don't want a translated copy. I thought there was something fishy about that, but that's a joke. Sorry, that's an appalling joke.
But to make it even better, we're actually blown away, and I'm sure Adrian can run down the list of the endorsements we've had for the document as well.
Yeah, we've and actually just most of you may have seen the little note that Anthony's just put up. You can download a copy of it for free from the website. But we went to the various colleges and asked for their support. It's been supported by the Royal College of General Practitioners, which I think is important because it means GPs are often a first line and they're the person you go to for advice. The Royal College of Physicians endorsed it, and the Royal College of Pathologists, which is the home of haematologists. The British Society for Haematology, which is a specialist organisation for haematologists in the UK, have endorsed it and will be available on their website through them. And two groups called the Genetic Alliance and the Rare Disease Association. I need to
Rare Disease UK and Genetic Alliance
have both support as well. They look at these sort of rare things. So we've been really fantastically pleased at the way the document has been received. And I think it's actually a very good document for patients, and it's something that, as necessary, we'll update in the future. We're hoping that we can produce something like that for children. The American Patients Association have written to Mervyn very recently saying how much they liked the document and they wanted to produce one for children, and would we like to be involved with them doing that? I think that's a great idea, and there's been even a discussion as whether we should try and produce one for pregnant women as well. And as some of you will know, we do have a pregnancy register for patients with ITP, so we're collecting patients' data who are pregnant with ITP, and we'll be presenting the ongoing results from that at the ITP convention next May.
Okay, thanks very much, Adrian. Okay, I've got a question here from Roger. Hi, Roger. Would you like, do you want to read out your question, or would you like me to?
I'd like you to, please. If you
No problem, sir. No problem. Okay. You're only saying that because of all the long names you've got on here of the drugs.
Exactly. Yes, you guessed.
Okay. Having tried rituximab, romiplostin, and eltrombopag, none of which gave any consistent benefit, I'm now being treated with mycophenolate combined with eltrombopag. Hopefully this seems to be working with counts of 150 to 200. However, this involves some nasty gastric side effects, excess saliva causing fairly extreme indigestion and coughing with wind from both directions. Has anyone else had the same problems? And if so, how have they managed to minimize these issues? Anyone? Before we go to Adrian?
It's gone very quiet.
It has. Tina.
Yeah, I mean, I can possibly
Hold on,
give
Anthony.
you some...
Tina had her hand up. Hold on.
Sorry,
Tina.
beg your pardon. I'll come back. No problem.
Tina.
Sorry, I was just going to say I was put on to eltrombopag and I coped all right for a couple of months, but I also have collagenous colitis. And after about 2 months, it just went to extreme diarrhea, and I do mean extreme. And I had to stop taking it. So I sympathise with Roger.
Sympathise, yeah. Anthony?
Yeah, I can only sort of give
my
experience.
Mycophenolate, wasn't you?
Mycophenolate, Mofetil, yeah, MMF, and I'm still on it now. I've been on it for some time, and it's serving me very well, I have to say. So I've got no complaints on the platelet count front. I mean, I'm well above 200 and have been for the last 3 or 4 years. So that is really pleasing. But I can certainly sympathise with some of the side effects that a bit like prednisolone, it also tends to keep you awake at night if you are on mycophenolate. I certainly have had that side of it. Yes, a bit of indigestion, but very little else, I have to say. So I'm very grateful for that. But yeah, can very much sympathise with indigestion and that sort of thing. And for me, it was keeping awake at night. That comes in fits and starts as well with mycophenolate. So that's my experience, but I haven't had eltrombopag. So I can't comment on any of that, I'm afraid.
Can I comment? Because
Jeff, go ahead, Jeff.
Yeah, sorry, I've been on MMF since March, basically. I was on the 2+2. I'm now down to 1 because they're trying to wean me off it. because initially obviously I was on steroids, etc. And then I've been on the Revelade, I would say, or Thrombocytopenia since the middle of August, now in 75 mg. But I was given lansoprazole as well, and which I was led to believe is meant to help your stomach issues and things. But I would just say I've had occasional issues, but I've never had anything major, nothing that worries me. But MMF, but I couldn't quite work out if it was the steroids or MMF, but I definitely had sleeping issues.
So it's certainly the steroids are associated with significant sleeping problems. They also stimulate your appetite as well. And I mean, certainly the latest ITP guidelines suggest that steroids are used in a short, 8 weeks at most, and then tailed off.
I had a bit of a disaster. Sorry, with the steroids, because I was diabetic, it made my blood sugars go vush.
Yes.
So actually I lost weight, which is unusual, but that's all been sorted out.
Funny enough, I was looking at some data earlier today for something I was doing, and came across a patient review, an article that had questioned patients about steroids, and something like it was 17% of patients having had steroids said they would never ever take them again, and around 2/3 said they'd only take them if there were no other options, just because of those side effects. What I was going to say is that the MMF certainly is associated with those sort of gut side effects in some patients. It doesn't affect everybody. In fact, it affects a minority of them, but obviously it can affect quite severely. The lansoprazole that Jeff mentioned is a sort of anti-ulcer drug that reduces the amount of acid in your stomach, and is quite good for things like heartburn, and may just help if you're having those sort of issues. I have to say, we don't gut problems with Eltrombopag Revelade are extremely unusual, and I have to say I've never seen anything quite as serious as Tina mentioned. But then, lots of people take it, and we only see a small proportion. But it's unfortunate if you do that. All drugs have side effects, and all drugs affect people in slightly different ways. And if you're in that minority that gets severely affected, then all you can do is come off it. The other issue that I would say is sometimes when the count's high and stable, we do try and do what they're doing with Jeff, which is wean the dose down to see if there's the lowest possible dose that keeps the platelet count up, but reduces those side effects as well. If the count drops, you can put the dose up again. If it remains stable, then you continue to drop it.
Thanks so much, Adrian. Libby, you got your hand up? I'll come back to you in a second, Roger.
Right.
You're on mute, Libby. There's a button down the bottom.
Bottom left-hand corner, unmute.
Why are you trying to find the mute button, Libby? Roger?
Can I just follow up?
Help?
Yes, thank you. MMF on its own did no good. I was in the sort of under 10s for the platelet count. It's the combination of Eltrombopag and the MMF which has produced these good results, but equally produced the side effects.
Yes.
We are following what Adrian said, which is gradually trying to reduce one or the other. I'm not sure which is the real troublemaker, until we can get an adequate platelet count and not feel as sick, basically.
It's quite a nice combination, MMF and Eltrombopag, or MMF and Remiflastin. Because what Eltrombopag and Remiflastin do is they stimulate platelet production. What MMF does is actually reduces platelet destruction. So you're actually attacking both sides.
Oh, right. I didn't understand that.
Disease process. So that's one of the reasons why we like to combine them, because then that just the two are acting together, and we'll put the count up.
Okay. Thanks so much, Roger. Libby, you're okay now.
Thank you, host, for unmuting me. I just wondered if you were still collecting vaccine data, because I couldn't see it on your website.
Yes, we are. We are. Yes.
Okay.
It is on there. It is on there. Yeah. And I've just written a piece about it again for the next platelet magazine that'll be coming out as well. So yeah.
Okay. All right. Thank you.
We've included additional questions within the survey, this is a good time to actually raise it. We've included some more questions in the survey to cover the booster jabs as well. So, yeah. Okay. That was at the request of Dr. Sue Pavo from.
I think how many?
It's about 305, 306 in this tranche we've got. Yeah.
That's a very good response. I mean, the early tranche, we combined our data with the American data, and that was published in one of the major blood magazines called Blood. Surprisingly enough, it's the magazine of the American Society of Hematology, just summarizing the early experience of patients with ITP who get vaccines, and that's where some of the data I was quoting earlier came from about the reaction rate in patients with ITP with the first and second jabs, and the total response and the responses to treatment. So it's very important that, in fact, I was talking to Sue Pevord, who's from Oxford, who's been collecting a lot of post-vaccine data and has published a bit about it, and she led with a group of us publishing a paper earlier in the year about how to handle patients with ITP during the COVID era. But we've been discussing, actually looking at the data now and putting a short report into the British Journal of Haematology, looking at the responses post-vaccine. Someone published something very recently, an American did, but of course, Pfizer vaccine in the States. So we thought it was quite important to put our data just so it could be looked at in comparison to the American data. So both we've combined our data with the Americans for publication, and now we want to contrast it as well. And it's really because of the sort of super response we've had from members of the association that we've got this really good data that I think will really help and guide what we do.
Yeah, we've had two surveys running. The first survey, right at the start of the vaccination process, we had about 230 responses on that. And then when additional vaccines were actually launched, we changed it and restarted it again, which is the one we've got to 305, 306 people. So overall, it's over 500, which is amazing. So, yeah. Okay. Any other questions, anyone? Bonnie, you got your hand up? Bonnie, then Ronnie.
Hello. Good evening, everybody. A quick question around a good platelet count to have your booster. So when I had my first Pfizer jab, just before I went in to have it, I had a platelet count and I was 17 and they said, no, you can't have it, come back. So I danced around a bit trying to get my platelets higher, and then I came back and then had the jab. So I'm due to have my booster next week. I've got a blood test on Monday. So I feel like I'm just going to wrap myself in cotton wool and just drink milk until then to hope my platelet count is good. But what's the recommendation at the moment around when not to, or what sort of levels we should be looking at? Because before it was don't take it if you're below 20. But what would you say? Because I want to be around 50 to have it.
Yes, I mean, it's in truth, there's no lower limit, well, possibly below 10 for not having the vaccine. Certainly, it's preferable to be over 30. 50 would be fine, there's no problem, but over 30 would be fine. Anything lower than 30, sort of 15 to 30, you can still have it. What we recommend there is that they use a smaller needle and put it more under the skin and deep into the muscle, and then you press on it for at least 5 minutes afterwards. So depending on how keen you are to have it, I mean, we've certainly recommended that and not seen issues. We have patients who've been in the survey who've had it at low levels and have not run into problems. But certainly if it's over 30, I wouldn't see an issue. If it's less than 30, if you're keen to go ahead, then just with those provisos. If it's less than 10, then probably you shouldn't.
Thank you. I'm not really, yeah, I'm not really keen to go ahead really, unless I feel my body's in sort of like a good sort of place. I see it that from that perspective, I'd like to be a little bit kind of more robust before it goes in.
Yeah, sure. I can entirely agree. What we've done occasionally is given patients a short course of either steroids or L-Trombopag, and we've used L-Trombopag just because it's a daily dose, and you know that if you're going to respond, it'll respond by about days 7 to 10, so you can plan it, starting it to, and if that just boosts your count by 20, that almost certainly takes you into a level where it's completely fine, and then you can stop it straight afterwards, and the count will drift down again. And certainly L-Trombopag will have no impact on your response to the vaccine, and a low dose of steroids.
Yeah, that's what I did before. I upped it. I was on 50 milligrams of L-Trombopag and then upped it for 7 days to 75 pre the jab. But the problem is now I'm on 75 daily. I think going to 100 might blow me up. So I'm not sure that's a good idea, or maybe it is.
It wouldn't be an issue, to be honest. We've gone up to doses of 150 to do it. I mean, the recommended top level is 75, but that's just because when we did the very original studies over 10 years ago of dose finding, we looked at 25, 50 and 75, and at 75, but there's certain patient groups where we use 150 without great problem.
Okay, that's great. And how long do you think between increasing your dose until having an effect? Did you say 7 days?
Yeah, usually about a minimum of 7 days.
Okay, brilliant. Thank you very much. That's really helpful.
Thanks very much, Bonnie. So Ronnie and then Alison.
There's also a chat question just come up from Libby on Avatrombopag.
Is there anyone on Avatrombopag?
Yeah. Probably not, except on a named patient basis, unless they're in Scotland.
Yeah, that's true. Yeah.
And Avatrombopag, which I think will be a very good drug, just has to go through the various tests. It works extremely well. It doesn't have dietary restrictions, and is well tolerated. So I think it will be a very good drug once it becomes freely available.
Deborah just said her son's on it in Ireland. So
yeah.
Yeah, he has had a count of 0. He has tried Romuplastim, L-Trombopag. He's tried the mixture with mycophenolate and still didn't get counts over 10. He has started on it, and last week he went from 0. He went from 0 to 20, and then the following week he went from 20 to 229 this week.
Okay.
So that's the first time.
Have we discussed this before, Debbie?
Yes.
We have, haven't we? Yes, yeah.
But this is just started on the
yeah, I thought we had. That's fantastic. I'm really pleased to hear that.
That's good news.
You both.
We thought we would never get over 10. So to get to 229 was like winning the lottery. Right. So we're paring back the medication now this week to see how he gets on next week.
Interesting enough, the Avatrombopag, which had many different names in the past, is much stronger in experiments than either Romuplastim or L-Trombopag. But for some reason, because the companies that had it, they never did the tests and brought it out. But it was taken over by Sobi, who decided to push it and market it. And I actually think it's a very good drug, and have thought so for at least a decade, and was waiting for it to come out. And I think it'll be very good. So I'm really pleased to hear that, Debbie. I know from our discussions you and I have had in the past that what a difficult time your son's had, so that's super.
Yeah.
Thanks much. Right, okay, Ronnie, then Alison, and then the lady with the name Nigel.
Or is it Bonnie? Was it Bonnie?
No, Ronnie next, I think. Yeah, Ronnie.
Can you hear me now?
We can, Ronnie, yes.
Yeah,
yes.
sorry. Sorry, this is not related to vaccines or anything. I really would like to know from Adrian Newland if there's been any data, or is there any information on ITP and statins. I'm asking this because I've looked around. I can't seem to find anything apart from one case. I've got high cholesterol. I've always had high cholesterol. My GP now wants me to go back on statins again, but that's where I started ITP from, because one of the side effects of statins is that you get bruising. And and I went to the doctors because of that, and they eventually said, no, you've got ITP. So I'd like to know if there's any correlation. Is there any information about taking statins if you've got ITP? Thank you.
I'm not aware of any relationship between statins and the development of thrombocytopenia, and it's you may see a casual association, but that doesn't mean causation. And one of the reasons I don't believe it's a significant cause is that statins have been so widely used around the world now and in this country. If there was a specific association between statins causing thrombocytopenia, it would have been reported and we'd know it through the MHRA. But I'm certainly not aware of it. I'll have another look. I'll have a little trawl through our literature and see if there's if anything further's come up. But I'm not aware of it being reported at all. So I would say if you require statin, you should go on it without a worry.
Yes, only it is one of the side effects that they list on their drugs list with everything, and it does say bruising, which is what I thought I had first of all, on my arms mainly, and thinking, well, what have I been doing to get this? But realised it obviously, I mean, I understand what you're saying, but I did wonder, I did find somebody who some while ago in Hull, I think there was a study done, and they seem to have some sort of problem with that. But apart from that, I've not managed to find anything else. So I wondered if anybody anywhere is doing any studies on that.
Well, the data will be collected, and certainly the companies doing statins will collect that. They do what's called post-marketing surveillance. Bruising doesn't necessarily mean thrombocytopenia. Bruising is very common as you get older anyway, and it's due to thinning of the skin. It comes under the rather unpleasant term of senile purpura, and it's because the subcutaneous fat gets thinner, and the vessel, the little capillaries get a bit more fragile, and you can get a lot of bruising even with a normal platelet count. I don't know if that's a problem with with statins. If they say bruising is associated but don't mention thrombocytopenia, it's almost certainly related to something like that.
Okay, yeah, no, it was all on my arms in places that it looked like somebody might have gripped them a lot, but not where you would normally bruise yourself.
Yeah,
so yes, it didn't look good. Thank you for that anyway.
Thanks so much, Ronnie. Thank you. Alison?
Hi, I was recently on Revelade and have just been put on romiflostim, but I get a lot of fatigue, and this fatigue affects my eyes, getting very heavy, my whole head, my body. Is this effect of the drugs, or is this an effect of ITP? And does anybody else get it, and what can I do about it?
I mean, it's very interesting you ask that, because I spent the last 2 days trawling data on fatigue in ITP, because I'm writing a chapter on it, and fatigue is very well recognized in ITP. I mean, we reported it through the ITP Association as long ago as 2010, and we did a review of patients, and we got responses to a questionnaire in about 200, and something like 25% of patients with ITP are permanently fatigued, and about another 25% get periods of fatigue where they don't want to do much. It does impact on work, it impacts on play, and it impacts on the quality of life.
It's changed mine completely. I'm a completely different person than I was.
So some of the drugs are associated with fatigue. I mean, steroids are, azathioprine is, even rituximab maybe. Interesting enough, some of the studies with romiflostim that have been published show that when your count improves on romiflostim, the fatigue actually improves as well. But of course, the fatigue in ITP is almost certainly related to what's going on within your bone marrow. It releases sort of hormones that cause tiredness. Now, of course, once the ITP process is damped right down, those chemicals that cause the tiredness reduce as well, and the tiredness improves. If you're you've still got ITP but are just managing to keep your count up, then you may still feel fatigued, despite the fact, and it's obvious you may think it's related to the treatment. I mean, the studies that we did in romiplastin were where we compared patients on romiplastin against those on what we call standard therapy weren't, and there was a difference between the two. Those who responded to romiplastin, their fatigue improved, didn't go away in everyone, but we still had occasional patients where the fatigue got worse. But in general, ITP is associated with significant fatigue in quite a proportion of patients. And again, in some of the children's studies, it was pushing 60%. Yeah, so these kids just didn't want to go out and do anything. But we find it affects adults equally. And as I said, the study that we did through the ITP Support Association and published in 2010 really confirmed that. There's certain conditions you have with ITP that may related to fatigue. I mean, if the thyroid isn't working very well, or you've got underlying rheumatoid or lupus, they can cause fatigue. But we know that ITP alone, with nothing else, on no drugs that could cause it, can cause you to be significantly fatigued. So it sounds as if you're one of these unfortunate people who is severely affected by that. And as you said, it affects your way of life. But it can get better. As the ITP settles, it can get better.
A couple of years ago, there was a worldwide survey done called the I Wish survey, and thousands of patients. And the number one issue that patients highlighted was fatigue.
Yeah, I can certainly confirm that when I was diagnosed back in 2006, it was the unremitting fatigue that prompted me to go and visit my GP in the first place. So that was the key feature of ITP, if you like, that prompted me to go and get checked out. So yes, it's the one thing I think that most ITP patients will talk about and complain about and recognise.
And are you better now?
Sorry?
And is it better now?
It is. I mean, as I said earlier, I'm on a drug called mycophenolate mofetil, which is commonly known as MMF. It's an immune suppressing drug. It can, in some people like myself, it can also keep you awake at night a bit. But
anyway,
that's been very successful for me. But of course, prednisolone and, as I've said, MMF are drugs that are well known to interrupt sleep patterns. So if you add that into the fatigue that the ITP is causing, then obviously it adds to the mix, if you like. So I've just put a little note on the conversation chat box. If people haven't seen it yet, I'd thoroughly recommend you have a look at a video on the ITP Support Association YouTube channel. Please do have a look at it. It's by Dr. Cindy Neunert, who gave us a fantastic presentation at the convention, the ITP Support Association convention last year, in May this year, on fatigue, how it actually crops up in ITP, why it happens, and how we can sort of draw from our experiences to combat it. So I'd thoroughly recommend that. If you've got sort of half an hour spare, grab a cup of coffee and have a look at it. It's a really good explanation of how it happens, why it happens, and what we can all do to try and mitigate some of the problems it causes.
I have to admit, I re-looked at Cindy's talk when I started writing my chapter, just to remind me of all the various issues. But it is very good. I just pulled out the I Wish study. It was 1,500 patients that they reviewed, and they were looked at questionnaires, and 80% of them complained of some degree of reduction in their energy levels, and nearly half required some assistance to do some of their activities in normal life. And it's been very important to us in terms of advising, because many clinicians, the ordinary hematologist, is worried about your platelet count.
Yeah.
And you say you're feeling a bit tired, and they brush that aside, because all they're interested in is what your platelets are doing. What you're interested in is what your life's like, because if your count's 30, it doesn't matter to you because you're quite safe. If you're not having any significant bleeding, it doesn't matter what your platelet count is. That's what we're trying to achieve. But how you feel is crucial to your life your well-being, your health and happiness. So we're trying to persuade physicians to take into account the patient rather than the platelet count. And that was the whole purpose of our shared decision-making document, that we want to get people, we want to get clinicians talking to patients. We want to get patients confident enough to ask questions to their hematologist to say, well, this is what's really troubling me. Not what a platelet count's doing when I'm not having any problems from it. So persevere, Alison, and as you've heard from Anthony, this can get better.
Thank you. Thank you.
Okay. There's a few people with their hands up. The lady is called Nigel.
Yes.
Then Derek, then Jane, and I believe Bonnie's got a hand up again as well. So.
Thank you. Can you hear me okay?
You can, yes.
Thank you very much, and hello everyone. And this is my first time at a meeting. I discovered I had ITP in June of last year. And funnily enough, the thing I wanted to bring up was the tiredness and the fatigue. And I was going to ask, do other people get this? Because that's, my platelets sort of go from 5 to 30. That's the sort of range with a few blips up when I get an infection. Yeah. So I don't know if other people have found that an infection will allow my plates to develop a bit. But I don't know if it helps, and I've to try and cope with this tiredness that wipes you out. And it also gives me migraines. I simply make myself stop and do nothing and sit in an armchair with the drink about 4 times a day. And whatever else is going on, I make myself do that. And somehow or other I can muster myself to be more active then, and to go for a walk or to do some cooking. And it's the only way I can get through things. So you've answered most of my questions, and I've heard that other people suffer, which is that makes you feel better to know that it's not just me. But I don't know if that helps anyone. But if anyone else has got good ideas as to how to cope with this wiping out tiredness and headaches from it, then I'm all ears.
To be honest, there's no specific treatment for it except treating the ITP and combining it with what I loosely call a healthy lifestyle. What you can't do is exercise through it, because that just wipes you out more. But how you handle it. But what you should still do is take some exercise, but with the rest interspersed as you do. And when I say exercise, I don't necessarily mean getting on a bike and pedaling for an hour. I mean, even if it's just going out for a walk or something like that, it's actually still trying to remain active, but not overdoing it. So I think what you're doing to try to keep active, because obviously the more you sit around, your muscles waste a little bit, you have less energy, and it gets harder to do things.
Yes. But it's very hard when, I mean, I used to ski a lot. I used to walk 20 miles a day. I used to go to the gym twice a week. And when you've been used to being very physically active, not to be able to, it's up here, you know.
Sure. Yeah, absolutely. But as you again heard, if they can find something that stabilizes your platelets, this isn't something that you're necessarily condemned to. It will get better.
Well, that's good to hear. Thank you. Thank you very much. Let's keep fingers crossed.
Yeah. Okay, Derek and then Jane. Derek?
I think, well, Adrian would say to me, it's because you're a geriatric, that's why you've got fatigue. But and there is certainly a fair degree of truth in that. But it does affect everybody, and it affects different people in different ways. I was fortunate. I had a good hematologist, and I lived for 10 or 15 years with a steady count of 10. Never worried, got very blasé about it until I needed heart bypass. Then, of course, major problems. But it was overcome, and I think that is the great thing. As it's already been said by you now, it's up here. It's a state of mind. You've got to get that right, together with living and getting the best quality of life that you can achieve. And it's only you that know how you feel and how you're going to achieve that. And it's a bit of trial and error. But otherwise, I think everybody's of the same opinion. They've all got the same views, and don't worry, just get on with life, I think is the answer.
Thank you very much, Derek.
one thing that people might find is that lots of people in the medical profession still deny there is any link with ITP and fatigue. I mean, by that we mean that if you're not dealing with a specialist ITP person further down the food chain, because ITP is still so relatively rare, you know, it's up to us to sort of re-educate folk that we might think should be educating us. So don't be afraid to throw that up to people and say that, look, this is an official symptom of ITP. It's well researched now. We have done a lot of work on it, and you can point to the work that the ITP Support Association has done on highlighting this. So
hence the need for this book, Anthony.
Absolutely, yeah, absolutely.
And if anyone would like a hard copy of this, I know it's available to download electronically, but if you would like a hard copy, just email us at the association and we'll put one in the post here.
And I'll also say that there's a patient booklet on the ITP Association website called Fatigue and ITP 2019 by a couple of American authors, Jim George and George Buchanan, who are both very eminent ITPologists in the States. And that's actually quite an interesting document that's written for patients. So I would suggest you have a little peruse of that as well. It talks about the issues of healthy living and stuff like that, but it's well worth a look, plus the shared decision-making book as well.
Okay,
Jane's had a hand up.
Hello, thank you. Me again. Let me take my hand down because I'll forget. Yeah, so basically, I had no symptoms. I just had a routine blood test in the GPs, the annual checkup, and my platelets were a bit low. So that started some kind of long journey of biopsies and what have you, CT scans, etc. So my unwelcome guest ITP was diagnosed. My question is, basically, prior to this, I had my own routine, and I had a number of supplements that I used to take, which were associated with some moderate arthritis in my joints, in my knee and my left hip. So I've been told by the hematologist that my normal routine of supplements, which I actually believe have helped to maintain my health, have all got to be stopped. And I think it was our friend just now was saying it's all in your head. I feel really uncomfortable about not being able to you know, being told to stop everything that I would normally do around my health and supplements and things like collagen, glutamate, things that are just part of my lifestyle for at least the last 10 years, which I do think have actually been of value to my health. And I'm conflicted really, because every time I think, well, sod it, I'm just going to go back to what I used to do, I feel conflicted because I also don't want to go against my hematologist, who is a specialist in ITP, and I'm very fortunate to have her. So I just wondered whether anybody else had this kind of dilemma. I have been good. I haven't started taking any of them, but I'm surely tempted because my arthritis, since I stopped it all, and you could say it's psychological, my arthritis has actually deteriorated chronically since I stopped taking all these. And you could say it is psychological, but it doesn't feel psychological, it feels pretty practical actually. So I just wondered whether anybody had any comments on that kind of issue. Thank you.
About 30% of adults with ITP are picked up incidentally, as you were. And if you have no bleeding problems, then if you hadn't had a routine test, you would still be normal. You wouldn't be suddenly called a patient and have all these tests and things like that. And certainly counts of above 30, and I don't know what your counts if you require treatment, certainly don't require any treatment. And we try and discourage regular counts. Now, there's certain things you take for arthritis, in particular what's called the non-steroidal anti-inflammatory drugs, the Brufens of this world, which you shouldn't take.
No, I can't take those anymore.
But I have to say, some of the other drugs or the supplements people take for arthritis, like glucosamine or chondroitin sulfate, there's no indication at all that those impact with ITP. And a number of people take supplements. I mean, some of us take vitamin D. I take vitamin D on a regular basis.
Yeah.
Vitamin C, which I don't take, also it may improve. Those, I mean, we used to use vitamin C in high dose to treat ITP. I doubt its validity from that point of view, but none of those impact on the platelet count.
Oh, that's very useful.
I wouldn't want to go
Thank you.
against. I wouldn't want to go against a hematologist. All I would say is, don't tell them.
Okay.
Thanks. Clear so
I
much, Jane.
I've had quite an unstable situation. I have to have weekly blood tests. I'm on L-Trombopag, but then my platelets go up by 100 each week, and then I have to go off L-Trombopag for a couple of weeks. So we've had a sort of merry-go-round for the last couple of months, up, down, up, down. We go up to 370, then down to 270, and so on. So she's just trying to stabilize it. She's discussing doing, I'm on 25 milligrams now, and I'm stopped at the moment because it went up to just under 400. And so it's a merry-go-round. Last time I saw her was just last week, I think. She's saying, well, we will stabilize it, but it will take some while to get it right. Maybe we can take one tablet every other day. So she's kind of working on it.
Yeah.
Trying to get it down again.
I think what she's suggesting now is the right thing. If you have a 2-week holiday, your platelet count will crash, if that's what you're going to do. So we tend to do what she's suggesting, which is take 25 every other day or every third day or whatever, because you need, if you crash, it means you need a small background dose. And it's a question of finding out what that background dose should be. And the best way to do it is to have those little gaps, but not a long gap.
Yeah. Thank you. That's really helpful. Thank you.
Thanks so much, Jane. Before we go to Bonnie, and then after that, Heather will be the last one. I've actually put the link in the chat for the ITP booklet on fatigue that Adrian mentioned, so people can download that. Brilliant. Right. Okay. Bonnie.
It was a really quick one.
And then Heather.
It was a really quick one about when we might get avatrombopag, and also I've done lots of reading about Dopletet, and I was just about your thoughts around when we might get avatrombopag and what your thoughts around Dopletet is.
Avatrombopag has to go through NICE before it can be approved for reimbursement here. They were supposed to be looking at it in the new year, but we heard very recently that they were actually going to delay that till next summer. Now we have challenged them and asked them if they would actually look at it earlier because of the need for it. Dopletet is in fact the trade name for avatrombopag. They're the same thing.
Oh, brilliant. That's
the same way that Revelade is the trade name for L-Trombopag and Nplate is the trade name for Uplistin. Dopletet is the trade name for avatrombopag. So we're really dependent on NICE giving the yes, because until they say yes, the commissioners won't pay for it. So you can get it on a named patient basis, but you won't get it routinely. And we were all a little bit cross that NICE have just casually said, oh, we're going to delay looking at it for 6 months because we're being a bit busy. So I think Mervyn's written to them, and the ITP Clinical Forum have written to them as well to say, look, this is just not appropriate. We want you to do it as you did. Is there anything we can do to support you?
And how do you become a named person for it?
Yeah, well, if there aren't other treatments that you can tolerate or respond to, your hematologist makes a request to the commissioner and say, I want to give this patient this drug because it has this effect, and she has no response to other things. Therefore, I think this is effective in her position. And quite depending on where you are in the country, some commissioners are very good at just approving a one-off treatment, others less so, but that's how you get a treatment on the named patient basis.
Perfect. Thank you very much.
Thanks so much, Bonnie. Heather, we make this the last one, I think. Heather.
Okay, hopefully it's a quick one. I'm actually in remission from ITP and have been for a number of years, but when I was undergoing diagnosis, after we'd got my platelets sorted to some small degree, one day I took to my hematologist a box load of supplements that I was taking, largely because my late husband liked to take them, so I was taking them. And the hematologist said, well, you can take all those if you want, and if you think they do you good, okay. But the only one he pulled out and said, this can affect your platelets, was omega-369. So if anyone's on that as a supplement, you might like to ask your hematologist about it.
And you presume you don't eat oily fish either. I have to say, I don't know about omega-369, and it's not something I'm particularly aware of. So I know there's certain things that I know can cause low platelet counts. I once had a patient who was admitted who was taking lots of seaweed. It was the iodine in the seaweed that poisoned her. We stopped it and the count bounced up again. There are one or two things like that. But to be honest, if you're taking unless it's one of the things we know has an immediate impact, if you're taking a supplement and your count is stable, it's not affecting you. If you're taking it and your count drops, and you stop taking it, your count comes up again, and you've done nothing else, then that supplement or that drug or whatever is impacting on your platelets. But the only way of being entirely certain is if you have a reaction to something you're taking, your count drops, you stop it, the count goes up again. But I have to say, I don't know of a regular association between omega-3 and low platelets. But I don't know everything. I freely admit.
Okay, thank you, Heather. Is there any more before we close? No? Okay, there's a couple of local group organisers on, a couple of you know, but just so you're aware, I will be making contact with you early in the new year, so we can have a little Zoom meeting together to try and work out the options for going forward with the local groups next year, hopefully, fingers crossed, as we come out of COVID, but we shall see. And just also, we are planning an in-person convention at the moment for next May. Details will be on the website shortly and in the platelets. It will be at the Royal College of Pathologists, COVID allowing. If COVID doesn't allow, then the backup plan B, if you like, is another virtual event. But fingers crossed that we will be able to meet in person. We may not have the numbers that we normally have, but hopefully, we can actually get together in person and shake people's hands again one day anyway. So
what date is that, Mervyn? What date?
You've got me now. I knew you said
May 4th. Is it May 14th?
The 14th of May. Saturday, the 14th of May, and I'm just double checking. I knew Rhonda would be the one. Yeah, Saturday, the 14th of May. Yes, at the Royal College of Pathologists in London.
Okay, sorry, I always ask awkward questions.
No problem. And as I also said before, if anyone would like a hard copy of our shared decision-making document, just drop a line to our email address info@itpsupport.org.uk. Just give us your postal address and we'll put one in the post here. So,
and I think one of the points to make about that too is it's not just shared decision making for ITP, it's shared decision making across the NHS for absolutely everything that you go to your doctor, your dentist, your nurse, whoever it is. That is the whole point about it, that it is for absolutely everything, so that you can work together with your clinicians. And I think I didn't have the chance to say to Alison, really sorry to hear about your problems with tiredness. I put a couple of comments in the chat, which I hope you've seen. And, this is something to really work with your clinicians. And if the haematology department are too busy for that, then to work with your GP and try and assess what you can do in order to alleviate your tiredness. And one of the other ladies, Lady Nigel, said that. And she was telling us very nicely about how she copes with it. And I think that is so important, is to find a coping strategy. And that is also when dealing with your clinicians, is to get someone on your side. You know, your GP may have a practice nurse who is very, you know, it has the time to listen and to talk you through and to support you in trying different things to alleviate your tiredness. And I know that there are a lot of people who've done that on their own. And I think also keeping a diary of what you do and how it affects you is really very helpful. And also sometimes with fatigue, people who have ME, one of the things that they do recommend is to have a very strict routine so that you can actually do something every day, no matter what it is, even if it's something really small. And that might just be getting out of bed and having a shower and your breakfast. You know, it doesn't have to be running a marathon. So I think that these are things that I've also written a few things about this kind of thing in the platelet, in back issues of the platelet, different lifestyle choices that you can make. So I hope that's helpful.
Okay, I'll just make 2 points before I go and join my wife to eat, and I hope the food isn't burnt. One, we're always very happy to answer individual questions. If you write into Mervyn, then when either myself or one of the other medical advisors, always very happy to advise. We won't counteract your own haematologist's advice, but we will give general advice on your questions. And the other points are, Anthony's made some very useful comments about some of the supplements that you take that are suggested will boost your platelet count. There's no evidence that any supplements will boost count. There's supplements that are good for your general health. And I think David has put a point on there from his ITP consultant who had no problems with fish oil. That's certainly my understanding of fish oil. It's good for you, but these things don't improve your platelet count. But there are 1 or 2 things that may make it worse. And as I said, Anthony's made those points there. So on that happy note, I'll go and have my burnt fry up.
Thank you very much, Adrian.
That's not very healthy.
No, actually, it isn't a burnt fry up. I just said that.
Thank you, everyone.
Thank you very much.
Thank you very much, everybody. Thank you. Goodbye.
If I don't see you again, happy Christmas. Take care.